Dr. Tariebi Cornelius. I'll be taking part in question 7. This is a 54 years old woman, known diabetic and hypertensive, had developed chronic kidney disease with worsening renal function over recent years. She presented with a 3 week history of foot ulcer, fever, and malaise. The ulcer opening was more superficial, but the bone was visible. Further evaluation of the ulcer using a probe showed resistance, but MRI did not reveal bone involvement. Patient was, however, febrile on admission. So the questions are, how will you treat the ulcer? The questions are in 5 parts. Question 1 have option A to E for you to choose an option. How will you treat the patient? Question 2 is, what is a comprehensive diagnosis? Question 3, what are the principles of management apart from glycemic control? Question, what classification staging system did you use in staging the disease? How will you classify the severity of diabetic foot syndrome and complications of diabetic foot syndrome? So in attempt to answering the question, how will you treat this patient? There are several options given. A, admit and give IV piperacillin and tazobactam. B, admit and give IV vancomycin and fluconazole. C is bone biopsy. I guess they also mean bone biopsy, microscopic question sensitivity. Then start oral antibiotics and discharge them. E, wound culture and initiation of oral antibiotics based on results of culture and sensitivity. I chose option C in the sense that for the bone is visible, and also there was probe resistance on examinations, meaning there's likelihood of having osteomyelitis in this patient. And for that, for bone visibility, that's also a clinical osteomyelitis until proven otherwise. So appropriate use of antibiotics is necessary for this patient. So culture of the bone biopsy and culture is more sensitive than the MRI to be used. So I choose option C. So in terms of what is your comprehensive diagnosis, I said diabetic foot syndrome, Wagner stage 3, because the clinical osteomyelitis patients already having at this point for bone visibility with severe infection on a background chronic kidney disease, and that on the background chronic kidney disease in a type 2 diabetic patient and hypertensive. So that's my diagnosis. I choose for severe infection because the patient has fever already. So for that, as a systemic involvement is already, systemic toxemia is also present in this patient. For that, I choose severe infection in this patient. There are several stages of infection, or it's mild, moderate, and severe. For patient to have systemic involvement, that also means that's stage 3. So that's I went for severe infection. So what are the principles of management apart from glycemic control? Now, management of these patients will involve a multidisciplinary approach involving the orthopedics, the vascular surgeons, the plastic surgeons, endocrinologists, the cardiologists, nephrologists, and nurses, podiatrics, dietitians, etc. I would like to offloading and bed rest of the patient, one of the principles, in that by taking away the patient to rest the leg, taking away the pressure of walking on that same leg to will impair the healing process of the patient. So for that, offloading and bed rest is very necessary for this patient. Debridement, and also debridement of the wound, which could be done both mechanical, autolytic, or biological means. Also too. Then also there's wound dressing, appropriate use of antibiotics, revascularization for patients that have vascular compromise, and peripheral vascular bypass surgery can also be done. Then limb limited amputation, DVT prophylaxis, because patients will likely be on bed rest and prolonged bed stay also for this patient, to prophylax for this patient, and identify and treat individual risk factors. If the patient have diabetic visual impairment, need for which they need to see the ophthalmologist also too, to review the patient, dietitians also too. And then if the patient have other cardiovascular risk factor also too, the patient need to be attended to. Like this patient also have a creatinine is already elevated, so the need for nephrologist also review this patient. Then classification system. There are several classification systems to classify diabetic ulcers. We basically talked about the size, depth, infections, and appearance and location mostly. Now that include the Wagner staging, which is the oldest staging system, Wagner staging system, University of Texas staging system, Liverpool staging, the PEDI staging, which is a perfusion, extent, depth, infection, and sensation. That's an acronym. PEDI staging system developed by the International Working Group for Diabetic Foot. Then the SIMBAT staging system, which is site, ischemia, neuropathy, bacterial infection, area and depth, and Nottingham staging system. For complications for diabetic foot syndrome, there is sepsis. Patient can have sepsis and become septic shock, acute kidney injury, bone involvement and risk of amputation of the limb, post-amputation complications like phantom limb. Then patient likely have venous thromboembolism, like the risk of venous thromboembolism, DVT and pulmonary embolism, lymphedema, and psychosocial factors too, like patient have developed depression also too. That's for the answer to the question. Then diabetic foot ulcer syndrome. We'll use the following a synopsis to present this topic. So diabetic foot ulcer syndrome was defined by WHO in 1995, which includes neuropathy, angiopathy, infection that will lead to tissue breakdown and resulting in morbidity and possible amputation for amputation. It's the commonest cause of non-traumatic amputation worldwide and a source of major medical, social, and economic burden. And it's a leading cause of hospitalization among diabetic patients. The average cost of care in a study done in 2021, so the average cost of care for a patient is about 300 to 500,000. However, if you want to put that in this our current 2024, that will almost double the current cost of care. Now, it's also the risk of reoccurrence about 50% in 3 years. More common in male and type 2 diabetics, and more in low socioeconomic class group, and account for 19.5 in a study done in Pastor Peter Teaching Hospital, and accounted for 19.5 diabetic deaths. The risk factors for developing diabetic foot syndrome could be classified into general and systemic contribution and local issues also too, where contribute diabetic foot ulcer syndrome. So that's male sex, diabetic for more than 10 years duration, peripheral neuropathy, abnormal foot structures, patient with bony abnormalities, callus, thickened nails, visual impairment, peripheral arterial disease, smoking, history of previous ulcers or amputation, poor glycemic control, and diabetic neuropathy, nephropathy, and especially patient on dialysis. Those are also risk factors for developing diabetic foot ulcer syndrome. The pathogenesis of diabetic foot syndrome is multifactorial, including peripheral neuropathy, abnormal foot biomechanics, peripheral arterial disease, and poor wound healing. Patients with peripheral sensory neuropathy will have an abnormal protective mechanism that will allow them to sense their foot when they walk around, making them at risk of developing minor or major injuries or minor repeated injuries, sometimes with the patient not being aware of them having an injury. They might have disordered proprioception in that when they walk, they have abnormal weight bearing, putting them at risk of developing callus and ulceration.
Please, yeah, have 1 more minute.
Oh, okay. It can be classified into ischemic, neuropathic, and neuroischemic ulcers. And 50% of the patients tend to have neuroischemia. Classification system, like earlier stage said before, these are the Wagner staging system, whereby initially the foot at risk, and also the stage 5, whereby the whole foot gangrene as occurred. They have the Liverpool staging system, and this was developed by a severity scoring system developed by Ubemise and Ubemudia. The diabetic food severity score, which includes color of the food, peripheral pulses, sensation, ulcer grading, food X-ray, and age of the patient to determine the risk of the patient, severity of the food ulcer of the patient. This talk, okay. We talk about severity of the wound infection of inpatient diabetic foot ulcer can be uninfected, mild, moderate, and severe. Like this patient I said has a systemic involvement, hence I said severe infection for patient. When they present, I'll take history regarding the history of peripheral neuropathy, history of peripheral sensory, peripheral arterial diseases like intermittent claudication, wound. And on examination, one would like to take the vascular examination, dermatological, neurological examination, and musculoskeletal examination, which in dermatological examination, want to check out for thickness, dryness, or cracking of the skin, musculoskeletal, there is deformity of the foot, neurological examination, like use of monofilament, vibration sensation, vibrations, and pinprick sensation, also vascular examination using foot pulses and also ankle brachial reflexes, and use of monofilaments. And there is 4. These are the 2 commonest sites for detecting monofilament examination. If 2/4 means the patient have loss of protective sensation. Also transcutaneous partial pressure of oxygen examination of the foot to determine the patient that would likely reel spontaneously. These are differential diagnoses, which include basal cell carcinoma, pyoderma granulosum, Kaposi sarcoma as differential diagnosis. On an investigation, I want to do an X-ray of the foot, including the distal and the proximal joints. Magnetic resonance scan also can be done, but bone biopsy is the gold standard for diagnosing osteomyelitis. And treatment is a multidisciplinary approach have to be followed for this patient using the following principle of earlier stated before: offloading, debridement, wound dressing, appropriate use of antibiotics, revascularization, and limited amputation and good glycemic control. Now for offloading, okay, we want to like take the pressure off the patient's foot while they walk, giving them time to heal properly. Whichever method of loading, it can be contact casting, can be used for protective gears for while they walk. These are examples of them. And debridement can be done mechanical or biological. Surgical debridement, or mechanical debridement, which can be turning the chronic ulcer into acute healing wound, and should be done regularly to remove all necrotic and callous tissues. Other modalities include use of enzyme, growth factor, cellular factor, hyperbaric oxygen. Then also that use of maggots for biological method, use of the green butterfly, Lucella seriata, siricata, sorry, Lucy, Elias siricata can be used, especially in ischemic wounds. These are several forms, can be free-range maggots and biofoams can also be used. Honey also can be used also too as a wound dressing. It provides good, moist healing environment, rapidly clears infection, deodorizes, and reduces inflammation, edema, and exudation. It increases the rate of healing by stimulating angiogenesis, granulation, epithelialization also too. And it's environmentally based costs and can be cost-effective method of dressing wounds. The other hydrocolloid dressing also too can be used. Now, in terms of infection, important to know that the germ itself is not the problem. Using this quote by Pasteur that the germ is nothing, is a terrain that which is a spine. Like most of the commonest organisms that are typically found to cause infection in diabetic foot ulcer syndrome are organisms that typically occupy those environments. They include gram-positive cocci like the staphylococci, including the methicillin-resistant staphylococci. Can also streptococcus also to the group A and group B streptococcus.
Should be rounding up.
Okay. For mild infection, can treat for 7 to 10 days. Severe infection for 2 to 3 weeks, and patient osteomyelitis can treat up to 6 weeks. Okay, these are the complications. For prevention, identification of high-risk patients, educating patients regarding education of the patient and teaching measures that will prevent further ulcerations. Now, for patients that are normal during examination, we can do annual examination of their foot, or those that have peripheral neuropathy, semi-annual, and those that have neuropathy and deformity can be done quarterly also too. In conclusion, diabetic foot ulcer is a disease. Prevention is the key method for preventing. Prevention of diabetic foot ulcer is the key. And thank you for listening.
Wow, thank you so much, Dr. Taribi, for that beautiful, detailed presentation. Okay, so now we'll take comments and questions first from the participants, and then we'll move on to our teachers. So you can raise your electronic hands or you drop your chats, drop your comments on the chat. And please, let's keep the thanks coming. Okay. So we have thanks on the chat.
Thank you so much. Thank you so much, Dr. Taribi.
Go ahead,
for that extensive presentation. You did a very good job. Okay, so what in your history made you pick diabetes mellitus foot syndrome? What's in the history of the patient made you choose that? Than choosing just an ulcer, that you had to choose a syndrome?
Okay. The patient is, from the history, the patient is diabetic, and also have a hypertensive chronic kidney disease, and the patient also have for the past also have bone visibility and also bone resistance, and the location of the ulcer made it, I think, of more of diabetic patient developing ulcer in the area in which diabetic foot ulcer is likely to occur. So that reason, for a patient with diabetic developing ulcer on the foot, I think diabetic foot syndrome will come into play. I think.
Okay, just an add-on. Okay, so the syndrome encompasses when there's evidence of infection. You know, the patient was actually presenting with fever, malaria, which shows there's some form of sepsis ongoing. And then there's also presence of an ulcer, and then there's a history of destruction of the tissues, and then probably the bone as well. So I think these three alone makes it a syndrome. You get what I'm trying to say? So the infective process, the ulcer, and then the destructive tissue involvement makes it a syndrome.
Okay.
Thank you so much.
Thank you.
Well, thank you so much, Dr. Florence. And just to add to that definition, I think they also gave the location, said distally from the ankle, and including the ankle. That's the foot syndrome, ulceration of the foot distally from the ankle, then associated with neuropathy and different grades of ischemia and infection. Okay, just to add to that. Thank you so much. Okay, let me go to the chat. I can't see any other hands up. Okay, so Dr. Taribi, a lot of thanks from Dr. Bimbola. Thanks so much. Dr. Blessing Azuko-Yamade saying thanks for the wonderful presentation. Dr. Gina, Dr. Mohammed saying thanks. Dr. Becky, Dr. Justice, thanks for the amazing detailed presentation. Dr. Jimmy, Dr. Adiboka, and Dr. Shamsuddin, Dr. Amadi Lomba, all they're saying thanks. And then Dr. Rita Iloka says, thank you for the presentation. One of the things you need to assess and control is dyslipidemia. Okay, I don't know that you added it.
Okay.
Okay. So
I think the individual risk factor should be put into place.
Okay, so Dr. Raleigh Omavore says, thank you so much for the beautiful presentation. Does the use of tetanus toxoid have any role in the management of DMFS?
Okay, I didn't come across that. I didn't come across that of tetanus toxoid, because I also think that if a patient having neuropathy, the spread of tetanus toxoid, that distal spread will be slow, and I didn't come across the use of it in the study because of
Okay. I thought there was a place for that. Okay, maybe an endocrinologist will clarify for us later. Okay, so let's take the next one. Dr. Nelum Neka says, thank you for the presentation. Please, there's a code for management of DMFS that was given on this platform some time ago. I don't know if anyone remembers. Okay, so I think we'll be thinking about it. When you say code, okay, like a mnemonic or something.
Yeah.
Dr. Nelum.
Yes, a mnemonic.
Okay. So Dr. Cassidy Ibe says, thanks so much for the presentation. Dr. Mamodu is applauding you. Dr. Vimpe is applauding you. Says, thanks for the presentation. Please, which probe was used to evaluate the ulcer?
Okay. Typically, they didn't state the particular probe that was used, but the typical probe that should be used should be a blunt end sterile probe. That's what typical should be used.
Okay. Thank you so much. The next question is similar to that. I think that's been answered. Please, what is probe to bone test?
Okay.
Dr. Ede from Dr. Ede.
I don't know a particular name for it, but I know that if for clinical osteomyelitis, if there is bone, if you can probe and get to the bone, that's also the definition of osteomyelitis clinically until bone biopsy and MCS is done. I don't know a particular name for it.
All right, thank you. I think maybe our colleagues will throw more light on that. Dr. Adeyemo Adedepo says, thank you for the wonderful presentation. Patient education, management of other comorbidities, and then the dietitian involvement are also part of a principle of management. But I don't know if you added those. I think you should add them. Thank you, Dr. Adeyemo, for that addition. Patient education, I think, is very important. All right. So Dr. Jamila says, thank you for the wonderful presentation. Okay, we've talked about this already. Please, what is positive probe test and negative probe test and the implications? Okay. Dr. Olariwaju says, thank you so much for the lucid presentation. Please, honey, though known to be moisturizer, but bonds and plastics are now shying away that it can be a cultural medium, I guess, for infection on the wound. So I need clarifications. Okay, so that's what we have on the chat. Okay, so there's a hand up. Dr. Mamodu, please go ahead.
Thank you so much, Chupekele. Good morning, teachers and colleagues. I just wanted to put emphasis on the clinical prone to bone tests. So the probe to bone test is just using, just as you said, a sterile instrument where you put it at the base of that ulcer and feel for resistance. If you have a gritty feeling, you understand, is a positive test, which is a clinical, you can say a clinical suspicion of osteomyelitis. So if you don't have that gritty substance or you don't have resistance, then it's negative. So you must have that resistance with or a gritty surface when you touch the bone with it. That gives the possibility and a possible clinical osteomyelitis. Thank you.
Thank you so much, Dr. Mamodu, for that clarification. Thank you so much. Okay. So Dr. Yahya Mohammed is also saying it's also good to look for other micro and macrovascular complications. And then Dr. Adeyemo, I think, is giving the mnemonic that Dr. Nelun was asking for, IgO-DPPPC. So I, infection control, glycemic control, O is offloading, D, dietitian, P, peripheral neuropathy management, the next P, PVD management, that's peripheral vascular disease management, and then the third P, patient's education, and the PPPC. Okay, we don't have any other on the chat. Okay, so I think we can move on to our teachers now. Okay, Mark Isabel, I don't know if our teachers have Any
Well,
clarifications, comments?
Hi, thank you so much. The presenter did well. This is first presentation. Dr. Taribi, thank you so much. Before I make my comments, I don't know, are there no endocrinologists in the house?
Yeah,
Yes,
I can cite Dr. Araga. I think it's here.
I know some. I just want them to. I don't want to put anybody on the spot. I want them to be. I want them to
Okay.
volunteer themselves. Is any comment from the endocrinologist in the house? If there's none, it's fine. It's okay. Dr. Kopi. Dr. Kopi. Dr. Kopi.
Yes, ma'am.
Yes, I
I'm
don't know
here.
if you, before I speak, I don't know if you want to make a comment because this is something you're familiar with. They didn't miss anything, but if you want to speak on this after we have, the usual, at the end of the discussion, let me know. So I'll put that in mind. Do you want to speak
Well, I think you did actually. From what
at the end of the discussion? Please, Dr. Taribi, please, we need to see your screen. I need to see that question. It's something I want to ask you. Dr. Gopi, do you want to speak at the end of the discussion?
okay, maybe let me speak at the end.
Okay, that's fine. And Dr. Taribi, please, we need the question. I think he has challenges sharing slides. While I wait for the question, Chief Chito, Chief Remigus, Chief Cookie, any comments?
Hello, Dr. Christabel. This is Dr. Shitzer. Good morning. Well
Good
done
morning,
to
sir.
the presenter. Yes, I think diabetic foot syndrome is something that tends to come out a whole lot in the exam. So it's one of those complications of diabetes that, in a way, you are kind of sure that the high probability of it coming out. It's important to be sure of the question. The first person that asked the question, I think it was the rep, that asked the question, are you sure? Why is it not just an ulcer? And why is it a syndrome? In answering that type of question, then you go back to the definition of a diabetic foot. If the person meets the criteria required for that definition of a diabetic foot syndrome, then you can say yes, it's a syndrome. So when you're answering that type of question, it's good to be direct and straight to the point and say, oh, because of 1, 2, 3, 4, 5, 6, which is supposed to be the definition of diabetic syndrome, and it's present in this particular patient, then you can now say that yes, it's a diabetic syndrome. It's the same thing with every other thing you're dealing with. Okay, once it fits the criteria for the definition, then that's what it is. Okay, then it's also important that whenever you're talking about diabetic foot syndrome, to mention the fact that it's a multidisciplinary management, and you have to mention the specialties involved, from plastics to ortho to the endocrinologist. Okay, sometimes even the vascular surgeon may have to come into play. Nurses, physiotherapists, you have to put all that, into perspective as well. And then please, because we're discussing diabetic foot syndrome, let's not forget about the diabetes itself and then other complications that do show up. It's expected that if a patient has neuropathy already, that the person may have some level of retinopathy and some level of diabetic kidney disease. So it's expected that that is already there, especially if the person has a type 1 diabetes, in which, of course, you know that all those things come in progression: the eyes, the kidneys, then the nerve follow. Okay, but in type 2 diabetes, all of them may be present simultaneously and even at the point of diagnosis. Okay, and may not follow that progression. But you're sure that there will be some deficit in the eyes and the kidneys if the nerves have an issue. So I just want to bring that to the front. But well done to the presenter.
Thank you so much. I want to thank you so much, Dave Chito. We really appreciate your consistency, your sacrifices. Thank you. Yes, I don't know. I think he's having challenges projecting the question. So I just want to just
Yes,
say,
he was locked out due to poor network.
are you serious?
He's no longer on the chat. Yeah.
He should come in now. He's free
Okay.
to come in. So I wanted to just say that in that particular question, even though it's a diabetic foot ulcer, when they did the probe, the bone were visible, but
What's
MRI
the
showed
name
you
of the presenter in case he was logged out and he needs to get it?
Caribe is not yet.
Dr. Tarebi Cornelius.
He hasn't come yet.
Stays in the
Tell him
waiting
to
room.
log in. He's not in the waiting room.
Okay.
So they said MRI showed no bone involvement. And he said the first line of action is going to be bone biopsy. I don't know. Why would he do bone biopsy when they told the clearly in the question, no bone involvement? Why not go for the option E we spoke about? I don't know. I was expecting the participant to ask that. Nobody did. Wood biopsy instead, then start a medication, a medication. So I don't know. I want he hasn't still come. Maybe his network is so poor. So I want to hear from him, his line of Dr. Kalamama.
Okay. The reason why I think they went for bone biopsies because the probe test showed it was osteomyelitis, but the MRI gave a contradictory results, meaning that the results were not tallying. So the next step of action is supposed to be a bone biopsy because that is the gold standard. If that says the patient has bone involvement, then the patient has bone involvement. So I think that was why bone biopsy was chosen because the two results were contradicting. So they wanted to go for an investigation that is definitive, that is a gold standard, which is bone biopsy.
Dr. Florence, look at the question. How will you treat the ulcer? Not what is your next step? Sometimes you don't say some of these things are a little tricky. You don't overthink it. How will you, as I wanted the speaker himself to want to hear him out
Okay.
and understand his line of thought. Say, how would you treat the ulcer? He didn't ask you what is your next line. Because these things you answer your question based on what they ask you. There are a lot of things in that question. So you want to know what are they really thinking. So you're asking about an ulcer. What is your how would you treat this ulcer? Not what is the next line of action. So
Okay, Ma. Okay. Okay. We had a discussion. I had a discussion with some certain persons as regards this. So some other
if it's
person
going
was saying,
to be
admit.
okay, if it's going to be on the the E aspect, we want it to be after the discussion when we put off our recording. That's why I gave Dr. Kopi. He went for that particular exam. As I gave him that
Okay. Okay,
particular
Ma.
when we off mic, he will now tell us all the
Okay,
secrets.
Ma. Okay, Ma.
So I
Okay,
want
Ma.
us to be thinking about it. Maybe at the end of the discussion, when he's speaking, we hear from him, hear his experience. But I was surprised nobody brought it up. But the question was, how will you treat the ulcer? Not the next line of action. So thank you so much. I don't know if he has come. The speaker is no, he's not here. So it's fine. We want to appreciate him in absentia. He has done very well. I think there is no more comment. We'll push this particular discussion to the end of this class. Dr. Ekele, the floor is yours.
Okay. All right. Thank you, ma. Okay. So Dr. Thelma Akumo. Please, you can share your slides. Hello. Hello.